This brings us to the last concern, concern number 4, impact and innovation. American medicine has a reputation for innovative, ethical, patient-centered, technically sound care. What happens when the only care that is reimbursed is standardized care approved by health plans and or government? What will happen to the innovations that occur every day in doctors' offices as physicians tease out new ideas, new strategies, and revolutionary solutions to fit the patient puzzle that sits before them in the exam room? Well, let me tell you a real-life story. A man in his 50s has a very unusual problem. A cyst in his throat, right here, threatens to cut off his breathing. Several times he's had it removed. Each time it returns. Desperate, several years ago he went to a major medical facility. The doctor there told him he could have no more surgeries. There was too little tissue left in this area. He told them his only option was to have a tube placed permanently in his stomach to eat and another placed in his neck to breathe. He cried as his wife drove him home. No more eating, no more talking. That was his future. He couldn't bear it, and as the cyst grew ever larger, he waited. He didn't want to die, but he didn't want to lose his ability to eat and talk. One day, out of the blue, in the midst of all this turmoil, he got a call. It was a radiologist he didn't know from the local hospital where he had had his previous surgeries. Unbeknownst to the man, this radiologist had been puzzling over the man's condition and had come up with a potential untested treatment, if the man was willing to try. The man was more than willing to try. The radiologist inserted a large needle into the cyst and drained it. It was very painful, but it worked. This simple procedure could be done any time in the future, keeping the man breathing and eating normally. Sounds simple, doesn't it? But it was very unusual and definitely outside evidence-based medicine protocols for this man's condition. The question to ask is, will standardization along with pay-for-performance hamper and impede medical innovations that save and improve patients' lives? Let's look at the future. Keeping these 4 concerns in mind, let's consider where our nation's new administration wants to take the practice of medicine. Peter Orszag, former director of the Congressional Budget Office, is the administration's budget director and healthcare strategist. The $19 billion to create a national system of linked online medical records, the $1.1 billion for comparative effectiveness research, and the 15-member Federal Coordinating Board for Comparative Effectiveness Research were put in the stimulus bill as a result of Mr. Orszag's efforts. In a 2007 presentation, Mr. Orszag promotes the idea of paying doctors according to the degree to which they prescribe effective treatments, as defined by the government. Here's what he says, and I quote, "The biggest return will come if you tie financial incentives to the results of the research. You can imagine systems of payments where financial incentives for providers are such that if they do intervention A, they are paid more than if they do the less effective intervention B, or some system where you still allow some individual physician flexibility, but try to provide incentives for what the evidence suggests is more effective." Mr. Orszag admires the National Institute for Clinical Excellence, which is located in England, acronym NICE, N-I-C-E. In his presentation, he calls it the, quote, poster child for comparative effectiveness research. But as former New York Lieutenant Governor Betsy McCoy recently noted in Bloomberg.com, NICE has a nasty reputation for healthcare rationing. Opposing the Orszag approach, she wrote, in 2006, a UK health board decreed that elderly patients with macular degeneration had to wait until they went blind in one eye before they could get a costly new drug to try to save the other eye. Thus, let me suggest that guidelines as guidelines are fine. But when they're tied to reimbursement and physician report cards or quality care measures, which is where U.S. policy is headed, they become mandates, as in the UK, meant to tie the doctor's hands and limit access to personalized, individualized patient care. Internationally renowned health economist Uwe Reinhardt has equated evidence-based medicine with managed care, saying the following: EVM is the sine qua non of managed care, the whole foundation of it, end quote. He worries that it will become cumbersome, ethically compromised, and ultimately useless. sliding into what he calls politics practiced in the guise of science. By all appearances, evidence-based medicine will soon become politics-based medicine, with a 15-member National Comparative Effectiveness Board deciding what medical treatments could even be researched to assess their effectiveness and thus be eligible for payment. This centralized decision-making model will inevitably lead to healthcare rationing, with evidence-based medicine becoming whatever the politicians and the political appointees say it is. My job today, as I see it, is to encourage you to look beyond the attractive term evidence-based medicine to see what is essentially a plan to centralize decision-making. Fully implemented, powerful players outside the exam room and far from the bedside will use EBM to take over the practice of medicine, endanger patients, ration care, and force physicians to violate medical ethics and the confidential patient-doctor relationship if they want to get paid. Let me suggest that the answer to rising healthcare costs is not the imposition of external bureaucratic controls like evidence-based medicine and pay for performance. The real answer to rising healthcare costs lies in enabling, promoting, and reestablishing internal controls. These include putting patients in charge of their own healthcare dollars, health savings accounts, and the purchase of true health insurance policies instead of today's expensive prepaid healthcare plans. In addition, we need doctors who avoid HMO contracts and opt out of Medicare and all of their bureaucratic administrative costs. The AMA recently had a study that showed that it's at least $70,000 per doctor just to do insurance. We should also encourage lifelong health insurance policies, membership in medical sharing organizations, and real charity. If this sounds a bit like the olden days, it is. Going back to the future is where real accountability, real cost consciousness, real markets, and real individualized prioritizing of healthcare decisions can bring costs down to size and patients and doctors back together in trusted decision-making that makes medical sense and financial sense. That's what the practice of medicine and true patient care has and always been about. EBM, on the other hand, will move us toward government-run healthcare and away from medical excellence. This will only increase costs, bureaucracy, taxes, and patient pain. In conclusion, and is no doubt clear, I would encourage you to cast a wry, discerning eye toward this new trend called evidence-based medicine and its newest little sister, comparative effectiveness research. Thank you.